Assalamualaikum and good morning to one and all. Today we'll study about part 4 of Purgative, anti-diarrheal and antispasmodic drugs. At the end of this e-learning session, you are able to discuss oral rehydration therapy and explain pharmacotherapy of very important GIT disorder, that is inflammatory bowel disease. So let's start with oral rehydration therapy. It is also called as ORT. So basically the oral rehydration therapy, it is first line treatment in most cases of acute diarrhea, because when patients suffer from the diarrhea, he is not only suffer from increase in intestinal motility or irritation of the GI tract, but along with the diarrhea there is loss of huge amount of the water and electrolytes. These electrolytes are very vital for carrying out normal functionings of the body. So if there is loss of electrolyte and if there is loss of the water, the patient will suffer from dehydration and he will also suffer from electrolyte imbalance. And most of the death which is occurred due to the diarrhea, so these cases of the death are due to the dehydration and due to loss of the electrolyte. So maintenance of these electrolyte, it must be the first line treatment, or it must be the first goal whenever patients suffer from very severe or acute case of the diarrhea. That is the reason oral rehydration salt, so the ORS, which consists of different electrolyte like potassium, sodium, and also there is presence of the glucose, which help in facilitation of transport of these salt into the blood. It is recommended by WHO, that is World Health Organization. So if patient suffering from the diarrhea, you must first give this ORS as a first line treatment to avoid any complication which arise due to loss of electrolyte and due to loss of the fluid from the body. Okay, so let's see what is the composition and what it contains. So the ORS, it consists of different salt. So first thing which is present in the ORS, it is the glucose, which is present at the quantity of the 20 gram. Then another important component, it is the salt, that is sodium chloride. It is present at the quantity of 3.5 grams. So 3.5 gram of sodium chloride, then 2.9 gram of trisodium citrate dihydrate and 2.5 gram of sodium bicarbonate. Lastly, it also contains potassium chloride 1.5 gram. So two important electrolyte, that is the sodium and potassium, which is very vital for normal functionings of your body and the systems, are present in this specific oral rehydration salt, which is also called as ORS. And other components like the glucose and tricitrate dihydrate and sodium bicarbonate, these are added into the ORS to facilitate proper transport of the sodium chloride as well as potassium chloride, and also glucose provide the energy. So glucose, it act as the source of the energy. So all these component, when you have to give to the patient, you can mix with 1 liter of the water. So you can mix with the 1 liter of water and you can give this 1 liter of water to the patient to drink at different time intervals. So based on his comfort level, he can drink this 1 liter of water of the electrolyte as early as possible, so that there is no possibility of dehydration which is occurred due to frequent passage of fluid stools from the body. So this is about the composition of oral rehydration therapy. Let's see why only this composition it is there, why there is specific composition. This is done because the composition of the ORS, it is very optimum, and it is optimum for rehydration of the patient of all ages. Now very good thing is that if you are giving any drug to the patient, you can see the dose of the patient, it is changed with the age. Like you are giving different dose to the infant, different dose to the children, likewise you give different dose to the adult. But this is not the case in case of the ORS. ORS, you can see that this composition of the ORS, it is optimum for rehydration of patient of all ages. So you can give the same ORS. So you can dissolve this ORS in 1 liter of water and that can be given to the patient. But yes, if it is the infant, he will not drink complete 1 liter of water because his body requirement it is also less. Likewise, children will drink less amount of the ORS, and adult, yes, he can drink complete 1 liter of the ORS solution. So this is how the composition of ORS it is optimum for all the age of the patient. Let's see the mechanism of action, how it's work and how it help in rehydration of the patient suffering from dehydration and electrolyte imbalance. Okay, so remember that when patients suffer from diarrhea, along with the diarrhea there is loss of water, and when there is water it is lost. You will always remember water also take along with them with different electrolyte, because water and sodium wherever they go together. Like when sodium it is enter into blood circulation, along with the sodium there is also entry of the water. So sodium entry is very important. Likewise, when there is a loss of the water, along with the water there is also loss of the sodium. So you must remember there is wherever there is the loss of the water, sodium will also loss. Wherever sodium is going, there the sodium entry it is coupled with the entry of the water. So sodium and waters are very important. And remember, although patients suffering from the diarrhea, but glucose linked sodium entry into the small intestine, it's remain intact, it is not lost, isn't it? So glucose linked sodium entry into the small intestine, it is remain intact even in case of the diarrhea. It means although patient is suffering from the diarrhea, if you give glucose and the sodium, that we have seen the glucose 20 gram we have used the sodium chloride. So if you give this salt and glucose together, the glucose will facilitate the transport of sodium from small intestine into the blood circulation. Okay, and it promotes sodium entry into the body cell. So if it is going into the blood circulation, obviously from blood circulation the sodium will also go into different body cell. So as I have mentioned, when sodium it is enter into the body cell, along with the sodium there is also entry of the water. Okay, so water will also enter into the cells. So since in diarrhea patients suffer from dehydration where cell having less amount of the water, and the patient also suffer from electrolyte imbalance, so both can be overcome by giving the ORS, that is oral rehydration salt, or you can by giving oral rehydration therapy where you are helping sodium by giving glucose along with that, which facilitate entry into the small intestine and which further facilitate sodium entry into the body cell. So this is how patient can be rehydrated if he is suffering from the diarrhea. Okay, so one more thing, why we have added potassium chloride. So always remember that when you want entry of the sodium, so suppose this is the cell membrane, this is intracellular compartment and this is extracellular compartment. So do remember there is sodium, it is present in a salt form, that is sodium and chloride form. Likewise potassium it is also present in a salt form, that is the potassium and the chloride. Okay, but whenever there is entry of the sodium from extracellular fluid to the intracellular fluid, at that time there is the exchange of the potassium. So when sodium it is going inside the membrane, potassium will come out because both are positive charge. So in order to maintain the balance positivity outside and inside, so when sodium it is entering inside, there will be the exit of the potassium. So when sodium go from extracellular fluid to the intracellular fluid, potassium will come out from your intracellular fluid to the extracellular fluid. And since in case of diarrhea there is a loss of both sodium and the potassium, so if you can give potassium chloride, this potassium will also add into the movement of the sodium inside the body cell. And as I have mentioned, along with sodium what will go? Along with the sodium there will be also entry of the water, which help or which facilitate rehydration of that particular patient. So this is how ORS it help in rehydration of the patient suffering from diarrhea. A very important thing, the ORS it is most important medical advance of this century. Now let's see what is the reason why ORS it is most important medical advance of this century. So first we'll see the reason and then we'll see what was the scenario before invention of the ORS. What was happening before invention of the ORS and how This problem it is overcome when the ORS was recommended by World Health Organization. Okay, so let's see the reason. So first reason, it can be used, you can see the ORS, it can be used to rehydrate 90% of patient with the dehydration. So it is very simple way of rehydrating the patient. So you can see it's not like many drugs, sometimes the probability of good therapy or the probability of effectiveness it is very less, and sometimes only 50% of population it works. So we have seen many drugs which having fantastic pharmacological action, but producing the effective clinical effect it is very less in the patient. So only 50%, sometimes it's work in 50% of population, or sometimes it's work only in 60% of population. But see here, the ORS it can able to rehydrate around 90% of patient with the dehydration. It means almost all patients except 10% of patients are rehydrated by using the ORS. So that is very good. Second thing is that it reduces hospital case of mortality by 50 to 60%. Because earlier what was happening, the patient when suffer from very severe dehydration, then their relatives taking that patient to the hospital, and by the time they take that patient to the hospital and the treatment it is start, there was death of the patient, especially due to electrolyte imbalance and the dehydration. So the death was very common due to the diarrhea before invention of the ORS. Whereas when ORS was invented, you can see not only it reduced the mortality rate at the home, but it also reduces hospital case of mortality by almost 50 to 60%. Okay, so this you can see this is the blessing for the treatment of the diarrhea. Third thing, the cost of treatment of diarrhea it is reduced up to 80%. Now very important thing is that when water it is absorbed into blood circulation, it will also reduce the consistency of your stool. So if water it is going into the blood circulation and it is absorbed from the small intestine, then instead of the fluid stool, that stool becomes semi-solid, because their entry of the water it is facilitated, because glucose is taking sodium inside the blood circulation, and along with the sodium water will also go, and which help in maintaining the normal consistency of the fluid, and indirectly it also reduces the diarrhea. Okay, so the cost of the treatment of diarrhea it is reduced up to the 80%. Earlier when patient suffering from the diarrhea, he has to hospitalize, whereas now there is no need to hospitalize, and now the diarrhea it is very common and no one is worried about the diarrhea. Whereas earlier if patient is suffering from diarrhea, it is considered as one of the critical condition, isn't it? So now that is not the problem. So when patient has to hospitalize if he is suffering from the diarrhea, it will add into the hospital cost, it will add into the nursing cost, it will add into the physician cost, right? Whereas now if you are suffering from the diarrhea, you can bring ORS from the medical store, add into 1 liter of water, and immediately you can start the treatment. Even there is no need to go to the hospital unless you are suffering from very severe kind of the diarrhea. Okay, so this is the third reason why ORS it is most important medical advance of this century. The fourth reason is ORS use at home even at early stage of diarrhea. So if you can use ORS at the early stage of diarrhea, so if you know that there is passage of 1 or 2 stools, isn't it? Because if you get up in the morning and you had the diarrhea for 2 times in a day, what you can do, you can immediately start the ORS. So if you use at early stage of the diarrhea, it can prevent dehydration. So there is no risk of the dehydration if you start it at early stage of the diarrhea. Fifth thing is that it is cheap and simple. Even you can make ORS at your home. You can add the sugar, you can add the salt, and in 1 liter of the water, and you can drink it. Even that can be the homemade ORS, right? You can add some the lemon into it. It become a flavor ORS which is made at the home, right? So it is simple. The lemon, salt, and sugar water. So that can also act as the ORS. But it is better to have the proper ORS formulation which is bring from the medical store, because that component or composition it is optimum for patients suffering from the diarrhea for all age of the patient. Okay, so it is cheap and simple. Another important thing, it is easily administered. Whereas if patient suffer from dehydration, then earlier case he has to hospitalize and given with the IV infusion. Do you think it is possible to give IV infusion at home? It is not possible, isn't it? So it is very cheap, simple, and it can be easily administered even by family member of the patient. So if you are young and adult, you can take your own dose of the ORS. But if you are children or you are the infant, even family member can also give or administer that ORS to the infant as well as the children. So looking at all these 5 reasons, you can see the ORS, it is the very important medical advance of this century or the current century. Now let's see about the another ORS formulation, that is called as improved ORS formulation. Now there is invention, it is keep on going on, and now they have developed improved ORS formulation. Let's see what it is and how it has improved the oral rehydration therapy, right? So the rehydration therapy, how it is improved by improved ORS formulation. So remember that this improved ORS formulation, it contains glycine in addition to glucose. It means all the component of ORS, it remains as such. What is added? You have added the glycine. So glycine, it is something which is extra that is added into the ORS. And if the glycine it is added into the ORS, this type of ORS, it is called as improved ORS formulation. And nowadays in most of the ORS formulation which is available in medical store, you will see the glycine, isn't it? And it is also called as glycine fortified ORS because you have added extra component of the glycine, so it is called as glycine fortified ORS. So when you add glycine into the glucose, what it will do? It will offer double transport mechanism for the sodium. So very interesting. So glucose will also help in entry of the sodium, right? And there is also entry of the sodium with the help of the glycine. So both glycine and the glucose will help in entry of the sodium from the small intestine, and as a result of that, in very short time, since you have given glycine and the glucose, in very short time, major amount of water from intestine and major amount of electron from intestines are absorbed into blood circulation, and it helps in control of the diarrhea, isn't it? Because if water is not remain in the stool becomes semi-solid, and if it becomes semi-solid, then the frequency of diarrhea will reduce. Okay, so this is the motto behind adding the glycine. What it does, it offer double transport mechanism for entry of the sodium. Let's see what are the advantage of the improved ORS formulation. So you can see the stool output, it is reduced by 50%. This is as compared to your ORS or normal ORS which does not contain the glycine. So it has improved or it is reduced by 50%. So maybe if you are suffering from diarrhea and frequency it is the 6th time in a day, and if you start ORS treatment, it will come down to 3 times in a day. Okay, so stool output it is reduced, and if you can able to control stool output, indirectly you will also reduce loss of the water and loss of the electrolyte. So this is another one important advantage. Secondly, duration of diarrhea it is reduced by 30%. So you can see there is additional advantages there. And lastly, amount of ORS required to control diarrhea, it is reduced by 43%, so almost 50%, because the sodium entry it is facilitated by both glycines and the glucose. So double amount of sodium it is entered with the into the from small intestine to the blood circulation with the same amount of the ORS, right? So requirement of ORS it is also reduced by use of the improved ORS formulation. So these are the different benefits which are offered by improved ORS formulations, and that is the reason nowadays the improved ORS formulation it is preferred over simple ORS formulation. So we have done with our first part of the session. Second part, that is pharmacotherapy of inflammatory bowel disease. Okay, so before going into the pharmacotherapy, first try to understand what exactly happen in inflammatory bowel disease and what is the pathophysiology, not into the detail but at least up to the certain extent, so that it is easy for you to understand the pharmacotherapy of inflammatory bowel disease. So the first thing you remember that the inflammatory bowel disease, it is not a single clinical condition. So there are two clinical conditions. It represent inflammatory bowel disease. The first, it is ulcerative colitis, and second clinical condition it is the Crohn's disease. Now one by one we'll see what do you mean by ulcerative colitis and what happen in case of the Crohn's disease. So first it is ulcerative colitis. So remember that the ulcerative colitis, it is diffuse mucosal inflammation, and this is generally limited to the colon. So now if you see the intestine, if this is the figure of the intestine, so this portion it indicates the small intestine, whereas this portion it indicates the large intestine, and last part of the intestine it is called as the colon. So especially there is the inflammation, it is occur in this portion of your intestine. So entire this portion of the intestine it is inflamed. If that is the case, if there is inflammation in the last portion of the large intestine, so that is called as the colon, that represent ulcerative colitis. And there is diffuse mucosal inflammation, means it's go inside of the mucosal membrane, so that is called as the diffuse mucosal inflammation. Okay, so I hope you understood this, the ulcerative colitis. So there is inflammation in last part of the large intestine, that is the colon, and there is diffuse mucosal inflammation. So this is happen in case of ulcerative colitis. Whereas in case of Crohn's disease, the patient suffer from patchy transmural inflammation. What do you mean by patchy and transmural inflammation? Suppose he is suffering from the Crohn's disease, there is inflammation at this portion, then there is inflammation at this portion, okay, and again there is inflammation is occur at different portion, okay. So what is this? This is called as the patch, okay. So since there is no continuous inflammation, whereas in case of ulcerative colitis we have seen the entire colon get inflamed, whereas in case of Crohn's disease patients suffer from patchy transmural inflammation. In addition to this, it also represents other clinical condition like the fistula. So you may have seen in case of some patient, suppose if this is the small intestine, some portion of that intestine it is extended, okay. So if it is extended, and the extension of that portion of the small intestine, that is called as the fistula. If patient is suffering from the fistula, then it may also lead to this patchy transmural inflammation, and it produces the painful condition of the intestine. Thirdly, it also represents the stricture. So what do you mean by stricture? Now suppose this is your the small intestine, and if the portion of the small intestine if getting suddenly narrow down, okay. So now suppose this is the original diameter of your small intestine, and then at this area there is a narrow down of intestinal diameter it is occur, and then again the normal diameter it is there, okay. So this posture it is called as a stricture. So again, since their patient suffering from the stricture, it will also add to the inflammation. So inflammation it is occur at the portion where there is the problem. It is not like that this inflammation in the complete colon, and that is the reason why in Crohn's disease there is patchy transmural inflammation, and it may occur at any part of GI tract. So there is no specific location where Crohn's disease occur. So if there is inflammation at different part of the GI tract, it is called as the Crohn's disease. And if there is inflammation only of the colon, that is called as ulcerative colitis. I hope this is more than enough to understand these two clinical conditions of inflammatory bowel disease, that is also called as IBD. So if patient suffering from this clinical condition, you can provide the treatment. So you can give the drug therapy. So there are three classes of drug can be administered to the patient to control this clinical condition. First, it is you can give the corticosteroid, because we know that corticosteroid they are anti-inflammatory in nature. So they reduces the inflammation, and by virtue of their anti-inflammatory action, they help in reducing the symptom of ulcerative colitis and Crohn's disease. And second, you can use the immunosuppressant drug, because sometimes the attack of the antibody on intestine it is responsible for the inflammation. So that is due to the excessive reaction of your immune system. So if you can able to suppress that by using immunosuppressant, then it can reduce the possibility of inflammation which is occurred due to the stimulation of the immunity or excessive release of the antibody which produces attack on your specific portion of the intestine. Okay, so the immunosuppressant drug you can use, and lastly you can also use the aminosalicylate. So we are using three category of drug: corticosteroid, immunosuppressive drug, and aminosalicylate. So in addition to this, you can also provide fixed diet to the patient, and so dietary and lifestyle modification it is also required to control the clinical condition of IBD, that is inflammatory bowel disease. Now we'll one by one see each category of the drug in the detail, because our interest is the pharmacotherapy, that is the treatment with the drug. So as I mentioned, the first category of the drug we use it is the corticosteroid. So drug belong to this category, it is the prednisolone. And since we are giving treatment of ulcerative colitis, and we know in case of ulcerative colitis which portion of the intestine it is involved, there is involvement of the colon. Okay, So the best formulation for the treatment of ulcerative colitis, it is either retention enema, which is inserted from the anus, or the suppository. So you can use the drug in the form of the enema of the suppository instead of using the drug by using the oral route or the IV route. And there are drugs which is given by oral route also, but best it is better if you give this drug by the retention enema or by using your suppository. Okay, so let's see what is the dose. So you can give the prednisolone retention enema. It is available in medical shop. You can give 20 milligram in 100 ml of the fluid, because we know the enema contains large amount of the fluid. So the drug dose, it is 20 milligram only, but it is given in 100 ml of the fluid, so that it can expose to large part of the intestine. So you can give prednisolone. How you can give it? So one edema at bedtime, it is given for 2 to 4 weeks. So when you are giving at the bedtime, patient is lying down, so there is less possibility of leaking out of that particular enema. So it ensures maximum contact of the drug with the inflamed intestinal mucosa. And as we know that prednisolone is anti-inflammatory, it will help to reduce the inflammation. So prednisolone retention enema, it is the first drug. Second, you can give the budesonide enema. So again, it is the steroid. But you can see the dose, it is less. So budesonide is very potent drug. So instead of 20 milligram, you are only giving 2 milligrams of budesonide, because budesonide is potent in nature. So it is given in isotonic saline solution. Again, you can give one enema at bedtime for 4 weeks. Okay. So you can see, since the dose is less, so it has to be given for 4 weeks, whereas prednisolone can be given for 2 to 4 weeks, depend upon how patients show improvement in the clinical condition of ulcerative colitis. Likewise, you can give prednisolone suppository. So if someone is not comfortable with the enema, you can give the suppository that can be inserted. So we have seen in last lecture, suppositories are the formulation which melt in body temperature, whereas otherwise it is present in a solid form. So you can give the prednisolone in suppository base. When it inserted through the anus, it will melt and it will help your colon, or it will expose drug to the colon. Okay. So other including hydrocortisone and methylprednisolone that can also be used, or corticosteroid, although we are using for the treatment of ulcerative colitis, but do remember that the corticosteroid are unsuitable for maintenance therapy. Now up to 2 to 4 weeks it's fine, but if even after 2 to 4 weeks of the treatment, if ulcerative colitis it is not getting control, then do you give corticosteroid? Obviously no. Why? Because as we have seen, the corticosteroid and all steroid, they are not good for the health. They produces very bad effect on the body. So to avoid that, corticosteroid are not suitable, especially for the maintenance therapy. So up to 2 weeks or 4 weeks, and that is too in the form of local application, because if you can see here, you are giving prednisolone, budesonide through the enema and the suppository. When it is given through the enema and suppository, its absorption into the blood circulation, it is very less. And if absorption into blood circulation it is less, you are exposing least amount of drug to the different part and systems of the body. But although this is less, but remember that it is not suitable for maintenance therapy of ulcerative colitis. So this is all about the corticosteroid. Second category of drug used, it is aminosalicylate. So it is used for treatment of symptomatic therapy. It does not provide complete cure of ulcerative colitis. Okay, so example of the drugs used are sulfasalazine, 1 to 2 gram can be given. You can give the mesalazine. So again, remember that the sulfasalazine, it is a derivative of the mesalazine. So both all are drugs are chemically related. They are all sulfa drug. Third category, it is olsalazine can be given. So depends upon drug. You can see there is different dose. Sulfasalazine you are giving 1 to 2 gram. Mesalazine 4 gram per day. It is given 2 to 3 divided dose. Whereas olsalazine 1 gram per day, it is given orally in 2 to 3 divided doses. So this is how you can give aminosalicylate, basically which are sulfur drugs. So let's see about little bit about sulfasalazines, because sometimes the question come in examination specifically on the sulfasalazine, and it's very important drug for the treatment of ulcerative colitis or inflammatory bowel disease. Okay, so as I have mentioned, it is the sulfur drug which is very common in all derivative of aminosalicylate. It is derivative of mesalazines, means earlier there is invention of mesalazine, and then you have added the group into a sulfur group you have added, and then mesalazine become a sulfasalazine. Okay, so it is derivative of mesalazine. It does not cure IBD because as we already seen, these drug aminosalicylates are used for the symptomatic treatment. Means it only provides symptomatic relief. So if there is inflammation, then patient suffering from the abdominal pain, and there is the problem while during the defecation. So these that pain and inflammation can be reduced, and it only provides symptomatic relief. It does not cure inflammatory bowel disease. Okay. So what symptoms of in IBD are decreased? So it decreases the symptoms such as the fever, because the patient suffer from IBD, sometimes they suffer from fever, obviously stomach pains and the diarrhea which is associated with IBD, and rectal bleeding. So these symptoms can be cured with sulfasalazines, which is seen in case of inflammatory bowel disease. It also increases the amount of time between the attack. Suppose due to IBD, patient suffering from the diarrhea, isn't it? So sometime patients suffer from diarrhea maybe twice in a week, and sometime maybe thrice in a week. So this frequency of attack of inflammatory bowel disease, it is also increased by sulfasalazine. It means instead of this attack it is occur within a 2 day, it may be prolonged to 3 day. Okay, earlier if it is occurring every 2 day, then it may prolong to 3 day, then it may prolong to the 4 day. So slowly when treatment it is advanced, you can increase the amount of time between the attack. So let's see what is the mechanism of action, how it's work. So what sulfasalazine it does, it reduces the irritation and the swelling in the large intestine. So if there is less irritation, now we have seen that one of the cause of diarrhea is irritation. So if you can reduce the irritation and provide a soothing effect, it also helps in reducing the diarrhea which is related to IBD or inflammatory bowel disease. Since it also reduces the swelling, it reduces the abdominal pain. So there is no stomach pain or abdominal pain because it reduces the swelling. So this how it's work, reduces the reduces the irritation, and it reduces the swelling by its virtue of anti-inflammatory action. Let's see what are the adverse effects of this aminosalicylate. So few adverse effects are there that you must be observed while giving the treatment with aminosalicylate. First one, it is hematological disorder. There is change in level of different blood cells. And we know that it is given through the oral route, so it may produce GIT symptom like nausea and abdominal pain, and it can cause reversible male infertility. So this is the major problem. So temporarily when you give this drug, this produces reversible male infertility by lowering the sperm count. What it means, if you stop the treatment, infertility will reverse. There will be slowly or gradual increase in the sperm count. So it's only seen during the period of the treatment, and once you stop the treatment, the infertility will reverse with aminosalicylate. So these are the adverse effects with the aminosalicylate. In addition to this, we can give immunosuppressant to reduce the attack of antibody on GIT. So you can give azathioprine 2 milligram per kg per day. It is used for in case of resistant case under strict supervision, because do remember that immunosuppression should be given under strict supervision, because it may lead to immunocompromised disorder. So there are some opportunistic infection, they are waiting for reducing immunity. The moment your immunity is come down, they will attack you and you will suffer from those disorders. So you can give this to reduce the attack of antibody on the intestine, and if colitis it is due to that attack of the antibody, so you can give the immunosuppressant. In addition to that, you can give the laxative. Suppose if patient suffering from the constipation and he is also suffering from the ulcerative colitis, then what will happen? There will be very severe pain during the process of defecation. So you can give the laxative like methyl cellulose. What this drug will do, they will adjust fecal consistency. Okay, so and due to adjustments of fecal consistency, the defecation, it is not difficult, and it will not be that painful for the patient suffering from inflammatory bowel disease. So immunosuppression can also be given. Let's see what could be the precaution. You must avoid anti-motility drugs. Why anti-motility drugs must be avoided? Like codeine sulfates and loperamide, it should be avoided because anti-motility drug produces the constipation, and due to the constipation, the condition become worse, and patients suffer from very severe pain in case of the abdomen or the stomach. Secondly, you must also avoid antispasmodic drug. Again, the same reason, if you give antispasmodic drug to avoid pain related to the inflammatory bowel disease, then it doesn't work. We have seen we are giving antispasmodic drug for pain related to the diarrhea. But if you misunderstood and if you give antispasmodic drug, then it may complicate the situation, because again it may be responsible for the constipation. It reduces your intestinal motility, it reduces the contraction, and it will affect peristaltic movement, and it may lead to the constipation. So two category of drug must be avoided for the treatment of inflammatory bowel disease. Last disease, it is the Crohn's disease. So treatment is almost similar to that of ulcerative colitis. Sometimes you can use aminosalicylate and oral corticosteroid because they are most effective in the treatment of the Crohn's disease. In addition to this, you can also give metronidazole. So sometimes Crohn's disease metronidazole work. It is used to combat the bacterial infection. Suppose the patchy transmural inflammation that we have seen in the figure in the second last slide. So if it is due to the infection, then that can be treated by the metronidazole. So this is how you can treat inflammatory bowel disease. So I have not again repeating the treatment of the Crohn's disease, because since it is same as the treatment is ulcerative colitis. So if separate questions come on the Crohn's disease, then all those drugs we have discussed in the treatment of ulcerative colitis will also come into the Crohn's disease. Okay, so this is how you can write the pharmacotherapy of inflammatory bowel disease. So I have referred this book, F.S.K Barar, Essential of Pharmacotherapeutics, S.K Chand Publications, especially for this chapter of purgative, anti-diarrheal and antispasmodic drugs. Okay, so I will be shortly releasing question and answer and feedback attendance link in the comment box. Thanks for watching my session. If you like my session, then do remember to give me a thumbs up.